Hello everyone, happy Friday. Wow, I am so excited to teach you guys about today's topic. So today we're going to talk about another movement disorder, and today we're going to talk about corticobasal ganglionic degeneration. That's like a mouthful. So last couple weeks we have been talking about MSA, about PSP, but I think today's diagnosis is my favorite one from all of them because it's so interesting. I haven't seen anybody with CBD or CBGD yet, but I just think it's so interesting. I was reading about it, I was reading articles about it, and I just feel like, wow, this is super interesting. So let's talk about CBD. So corticobasal ganglionic degeneration. In every large neurologic practice, there are a number of patients with the clinical presentation similar or that resemble Parkinson's disease, but their features clearly distinguishes them from classic Parkinson's disease. So in other words, their symptoms, they don't fit with your Parkinson's disease, okay? These patients are similar to Parkinson's disease, but they have a very clean presentation. You will see. So in 1967, and I'm taking you way back, okay? These three people, Rebes, Colony, and Richardson, described three patients with a progressive, asymmetric, akinetic, rigid syndrome with apraxia. So now here we're thinking, akinetic, rigid, Parkinson's disease, but then apraxia, you're like, what? So they labeled these three cases as, crossing fingers I pronounce this right, cortical dentatonigral degeneration with neuronal achromasia, which neuronal achromasia, I was looking at it, and it's just an abnormal, ballooned neurons that are found in some neurodegenerative diseases like CBGD or Pick's disease, I believe. So now they describe some of these patients, and they found, these rigid apraxia, and what is going on? So I actually found an article that is in the neurology journal, and it's literally called Corticobasal Ganglionic Degeneration, and they describe a couple patients, and I just want to read you guys some of the patients' descriptions, and then we're going to talk about the actual clinical features. So this is a 52-year-old housewife that noted a tremor of her left hand aggravated by action or anxiety. Now, 4 years later, she developed stiffness and slowness of the left arm and leg and slurring of speech. Then she began having difficulty arising from a chair, and her left hand became progressively more difficult to use, especially for dressing. So the examination disclosed an action tremor of both limbs, upper limbs, more prominent on the left side rigidity and akinesia, and generalized hyperreflexia, also greater on the left. She was giving trials of levodopa and carbidopa, which was not effective. So when she was asked to perform a movement, there was either no motor response, or the limb or the other limb will make an incorrect movement. So then the patient would say something like, I'm trying, or I can't. Her tremor then became very irregular, and the amplitude would change, becoming more like a myoclonic. So then she developed repetitive movement that she couldn't control in her right hand, such as like taking her glasses on and off, or like just moving the hand like she wasn't controlling, or raising the hand to the face. So this was more like an alien limb. So this is the first case. This is the second one. A 61-year-old surgeon developed difficulty gloving, tying knots, and manipulating instruments with his left hand. Then he stated that he seems to have forgotten how to use his hand. Then he began to like trip with his left foot. He was soon forced to retire as a surgeon. And then later the neurologist found an action tremor of the left hand, limb rigidity in the left side, and just like awkward movements of the left hand. Levodopa was ineffective. Years later, he developed difficulty manipulating his right hand and abnormal posturing of his left arm. The following year, he became unable to write because he could not figure out how to do it. And then he began falling a lot. And then he also had difficulty reading because he could not turn pages, and he had difficulty shifting his gaze from one line to the next. So here, as we hear these two cases, there are a couple of things that stood out to me. It started on one side and then, the other side. And then the apraxia, I can't, I'm trying, or like, I don't know how to do it. And then the last one was, with the surgeon, he couldn't move his eyes because he had trouble moving, reading from one line to the next. So that sounds like an apraxia of the gaze. So with CBGD, symptoms begin around like 60 to 80 years old. Males and females are affected equally. And as you can see, the characteristics are very clean, like they are very specific. So you start with one side, so it's asymmetric, and then it becomes symmetric as the disease progresses. So the core clinical features are asymmetric rigidity and apraxia. So again, it starts on one side, then it goes to the other side. Now, patients usually describe their limbs or their limb as like incoordinated or like clumsy, or like the patient, I'm trying or I can't. And then as it progresses, it becomes profoundly apraxic. So now if we think back to our types of apraxia, there can be idiomotor apraxia with the inability to correctly perform or imitate gestures or simple activities. So when they're asked to perform the activity or a gesture with the involved hand, they kind of like see the limb and they kind of question what they're going to do, or like they're just visibly struggling. Other neurologic examination features include the oculomotility disturbances, apraxia of gaze, problems with convergence or vertical and horizontal gaze. Now, this brings us back with the similarity to PSP, where they have difficulty with vertical gaze. So the difference between this and PSP is that CBD have trouble with both horizontal and vertical ocular mobility. Now, also the saccades, the horizontal saccades are very slow, because of the apraxia, but this is very specific to CBGD. They also have hyperreflexia, focal myoclonus. Now, myoclonic jerks is like a rapid ballistic that occurs sporadic. So it's not regular as a dystonia or like dyskinesia, okay? So it's a myoclonic jerk, okay? Now, another thing that they mentioned was the alien hand syndrome. The arm was kind of like moving on its own. So alien hand just means, quote unquote, circumstance in which one of the patient's hands behaves in a way which the patient finds foreign or like weird, like an alien. So this alien hand syndrome is associated with spontaneous levitation of that arm. So they're sitting and this arm is kind of just like doing its own thing. So that's the alien hand syndrome. So if you think about all the motor difficulties, akinesia, rigidity, tremor, myoclonus, apraxia, sometimes dystonia, the limb gradually loses all useful function. So the other thing is these patients might come to your clinic saying, I have a rapid increase of fall, I'm falling a lot per week, and there's no explanation to the falls, right? So that's something that you should keep in mind. Neuropsych testing in these patients typically will show deficits in frontal, striatal, parietal, cognitive domains, executive function, attention, concentration, language, and visual spatial functioning. Also, they might show impaired graphesthesia. It just depends on which hemisphere is affected. Now, autopsy studies of CBD brains show that these patients have bilateral atrophy of the precentral gyrus and neuronal degeneration of the basal ganglia, specifically the substantia nigra, and the presence of achromatic neurons, which I said are like balloon neurons or swollen neurons that are present in diseases like CBD or other tauopathies. So, that's CBD. That is corticobasal ganglionic degeneration. And, a couple of things that we need to keep in mind when we work with these patients. We can teach compensation for sensory issues, work in using vision when possible to compensate for the apraxia. Multiple cues. If they have the apraxia, like showing them pictures of, the sequence of doing something. Correct errors by imitation and physical manipulation. And these patients might not be able to use an assistive device because of the apraxia. So you need to think about it when you're prescribing that, okay? So I hope this was helpful. And now you know a little bit of CBD, and I will see you next time.